Hello, everyone. Welcome.
Walk safely.
Feel free to unmute yourself and let us know where you're zooming in from, and turn on your camera if you like. We're hoping this will be very interactive and we'll have lots of great discussion tonight. So we'll just let people join here. It'll be a couple of minutes and then we'll get started. But feel free to let us know where you are zooming or calling in from and what your role is in long-term care. Say hello.
Hi, Jessica. I just used the chat, zooming in from Burton. I work at Arrow Lakes Hospital and mental health and long-term care as a nurse.
Welcome. Thanks for being here.
Hi, I'm Jim Howie.
Hi, Jim. Welcome.
Hi, Jim. Welcome.
Hi there, Trevor. Yeah, I work in Kamloops. I just do long-term care. I work at.
Cool.
Pardon?
You're very well. Welcome. And Dale Nichols here. And I
Yeah.
see here. Hello. Welcome.
Hi, Trevor.
Welcome. Glad to have you. Yeah.
Hi, I'm Diane Wallace from Nanaimo. I work in long-term care, just long-term care, and I'm the long-term care initiative lead for the division.
Welcome. Yeah.
Thanks for coming.
Hi.
Go ahead.
I'm Bonnie Lynn. I'm the resident care coordinator at Columbia View Lodge and Trail.
Wonderful.
Oh,
I see Dr. Stephanie Hood here. Stephanie is a emergency room physician in Trail. Stephanie, thank you so much for joining. I would invite your comments. I was going to badmouth orthopedic surgeons and emergency room docs, and I have to be careful because I know you're in the room as a hospitalist and emergency medicine physician. Yeah, so the fact that you're on this call and thinking about hip fractures in frail seniors is a real credit. Thank you so much for joining us, and we're really looking for your input on how we can have these conversations happen, not just in long-term care, but in the hospital and among orthopedic surgeons as well. Yeah. Who else wants to introduce themselves? Welcome.
Hi, Trevor. This is Catherine. I'm a nurse practitioner in Victoria, and this is a topic that's of particular interest to me and our team gets some work on.
No, I just saw her last week, and she was heading off to the Family Medicine Forum in Victoria, and then she's been back and forth to Calgary because of her.
Oh, I think we've got, yeah, if you don't mind keeping yourselves muted if you're not talking. Catherine Ryan is the co-author of the hip fracture one-pager that I shared with you.
Catherine, that's fantastic. We're going to be showing your work to all these people, showing your wonderful work to all these people. Thank you so much for that. Well done. That's very useful.
Yeah, thanks, Trevor. I'm really looking forward to this session.
Yeah.
We'll just do a couple of housekeeping items here first before we get started. So I'm Jessica. Welcome. I'm the Victoria South Island LTCI Program Manager. Would like to welcome you today to our LTCI Learning Series event with Dr. Trevor Janz. It is with great respect and appreciation that I am speaking to you today from the traditional and ancestral territories of the Sauk Nation, where I am very, very lucky to work and live. Feel very grateful. In terms of housekeeping, please keep yourself muted during the event unless you'd like to ask a question, just because that background noise can amplify quite quickly. This is a CME event, so a certificate will be emailed to you in the coming days by a member of our team. And please take a moment to fill our evaluation form at the end of the event. So that'll help us inform future events. So if you take a moment to do that, that would be wonderful. Thank you. We will record this event and it will be posted on our website. So please feel free to share that link with anyone who wasn't able to come today. We will send that out to you. Yeah, and if you have any questions throughout the evening, please feel free to unmute yourself and ask away. Like we said earlier, we are hoping that this will be a very interactive event. So put your video on if you feel comfortable and unmute yourself. And yeah, let's have some chats. So over to Dr. Trevor Janz to introduce himself.
Hello, welcome everybody. Thank you so much for showing up on.
Yeah.
contributing an hour and a half of your evenings for this conversation. I'm Dr. Trevor Janz. I've been doing long-term care for as long as I can remember. I'm a medical director for long-term care for Interior Health East. That's in Nelson and the East Kootenays, as far all the way from the Alberta border to past Kelowna. Yeah, that is my territory. I'm the author of Your Loved One Has Dementia, Frailty Roadmap. And good news, this is the dementia roadmap. The frailty roadmap is coming out probably within this next month or two. Vancouver Coastal said we need a frailty roadmap with dementia, without the dementia language, for people with frailty without dementia. So there's a frailty roadmap coming out very soon. So I wanted to talk to you about, I have no conflicts of interest. No drug company has ever paid me to tell you to take all your frail seniors off of all their pills. So I don't have any conflict of interest. I want to talk about conservative management of hip fractures, a palliative comfort care approach to hip fractures for people with late dementia and frailty. When I first started in long-term care, everybody who had a hip fracture went for surgery, and it didn't take a long time for me to figure out that lots of people died at the hospital or came back and died with me. And within a few years, I was starting to choose who we should send for surgery and who we shouldn't. And I've had lots of practice with that, and lots of practice with making people comfortable and treating them with comfort care in facility and managing that very successfully. So that's what we're going to talk about today. I'm thinking there are 4 things that I want to cover today. I think probably the first one is this a hip fracture or isn't it? And then, so we're going to decide if the hip is broken, and we're going to talk about how you can do that right in the facility without having to send them for an x-ray sometimes. And then talking about deciding who should get surgery and who shouldn't. What are the inclusion criteria? What are the exclusion criteria? How medically frail are they? What is their surgical risk? Should we even suggest it to the family? And then probably the bulk of the evening is going to talk about that conversation with families, about how to help families come to the right decision for their loved one. And then the 4th and final task that we need to talk about tonight is, if we're deciding on comfort care, can we provide excellent pain and symptom management for this dear poor senior who's got a broken bone? Can we look the family in the eye and say, I can keep your mom comfortable. She does not have to suffer. She can die quietly and peacefully if now is her time, or she can survive and get through this, and we can treat her in the facility. So 4 jobs. I would love this to be a conversation. I'd love for you guys to jump in, put your hand up. Jessica, I'm counting on you. If you see hands up, to just jump in and interrupt me. I'll try and stop periodically along the way so that we can invite questions. Yeah, that would be lovely. Kathy, I see you there. Thank you. Kathy Hendry, welcome. Lovely. It's lovely to see familiar faces. So back in the old days, we sent lots of people for surgery. And if your patient is a sturdy walker and is stable physiologically, and they're going to survive surgery, not only are they going to survive, they're even going to walk again. And they have a good quality of life. They're not too demented. They're enjoying their life. They want to live for longer. Even though they may be weaker, they may not walk again. It's worth doing the surgery. Then all that means we should be doing surgery for this person. And I have a few of those residents in my building, but they're not the ones who fall and break their hip. All the ones in my building who fall and break their hip, especially now, as my residents have gotten older and frailer over this last 5-10 years, the vast majority of my residents who fall and break their hip are more rapidly declining. If you've got a long curve down into dementia, if your trajectory is gradual, slow change, and then it speeds up, and you do a sudden downturn and change relatively quickly in that last year of your life, and especially in the last 6 months, that's when people are falling, and that's when they're falling and breaking their hip. And those are the ones who are least likely to benefit from surgery and most likely to just die anyway. So the trick will be for us to find the ones who are in the good part of their trajectory, that are stable physiologically, will benefit from surgery and survive, and make sure that they get that and do that best that they can with that. But for most of my patients who break their hip, I don't have many of those that break their hip. I have some of them in the building. Yes, I have physiologically strong people, but they're walking strongly and they don't fall. It's my frail ones who fall. So if they've got declining mobility, if they're not feeding as well, if they're less and less aware, they've got more dementia, if they've got a poor quality of life, they're probably in the last months to year of their life, they're in that declining phase. If they've got a very poor quality of life due to their dementia or their severe frailty, maybe they're not having much fun. And we're going to talk with families about that quality of life piece. Those are the ones that I want to identify and save them the potentially burdensome medical intervention of a surgery that's not going to make their life better. They may survive the surgery, but they're still just as frail and they're going to be even more frail than before, and they're going to do badly. I don't want to do surgery and have them die within the month. Those are the ones I like to avoid. So for those ones, I'd like to offer them the humane option of comfort care, and we need to do that. Now, the problem with having a conversation about comfort care for a hip fracture is that you need to have that conversation a long time before the hip fracture happens. If we haven't given the family any warning at all and their loved one is getting more and more frail, and we call them up on a Thursday at 10 o'clock in the morning and say, your mom has just fallen. We think that she's broken her hip. She's got about a 70% mortality. She may die within this next week. Should we send her for surgery or not? You've just sent that family member into a tailspin. If they've got any trauma history at all, they're going to go into complete overwhelm. They're not going to hear anything that you've said. You're going to freak them out. The best way to have these conversations with families, not right when they have their fracture, is to start the conversation ideally a year before that, while they're still walking strongly. I have these conversations when they come through the door, and it's not one conversation, it's a number of conversations as we get closer to forgetting how to walk and starting to fall. I have these conversations at admission or usually at the very first care conference. And the care conference is a lovely setting for that, because we're getting to know the resident, we're going through all their medical diagnoses, we're getting a sense of their medical frailty, we're hearing from the care staff about what they're able to do for themselves and what things they need queuing for in terms of dressing, grooming, toileting, how safe are they walking, how well are they eating, how much cognitive impairment have they got, and especially how quickly are they changing. At that care conference, one of my most important questions is, has this person got years to live, or 1 year to live, or months to live, or weeks to live? And I need the family to tell me in the 6 months before they came in how much they've changed. And that will really color the conversation. If they've changed significantly and lost significant abilities in the last 3 to 6 months, we know that we need to have these conversations much sooner than if they barely changed at all. But very few of the residents that are coming in that I'm admitting right now are in a long, stable phase. They don't come to me anymore. I only get the frail ones who are coming apart. We get the ones that are really not doing well at all. So that advanced care planning conversation, I want to ask a number of questions to get the family ready. I have probably 4 questions that I go through as a standard thing. The first is the CPR ICU do not resuscitate conversation. We've all had that conversation. We know how to do that. The PATH project in Halifax had a lovely conversation guide about this, and they called the CPR conversation a non-decision. They say, we're not going to decide about this today because it's not on the table. This is not really an option that helps your very frail senior. This is not something that we even offer in long-term care. And let's be careful, there are 15-20% of residents in long-term care who don't fit the very late, very frail, very demented. Those are the mental health, substance use, the mobility issues, the complex medical ones. And it may be entirely appropriate for them to have a CPR conversation. But for the late frailty, late dementia ones, the CPR conversation is a non-decision for most. I can reassure them this is not going to help them, and it's not anything that we'd like to do for their loved one. The ones I need their help with, though, I've got 3 questions that I need to ask you. And ideally, the resident is right there. I really want resident and as many family members as possible. Because of your high blood pressure, because of the fact that you've had TIAs before and you had that one small stroke, I'm quite concerned that at some stage you're going to have another stroke. And I need to hear now, and especially your family needs to hear, if you had a big bad stroke and you were totally paralyzed on half of your body, so you couldn't walk at all, and you lost your ability to speak, so you couldn't tell us what you wanted, and you lost your ability to swallow, so you couldn't eat or drink anymore. There are some people who would want us to put a feeding tube in through your nose, down into your stomach, to feed you milkshake to keep you alive. Your family and I might need to make that decision, because you won't be able to speak for yourself, and we really need to hear from you today. If you couldn't walk, and you couldn't talk, and you couldn't eat, you couldn't swallow, and you might or might not be in a coma, would you ever want a feeding tube? And the residents almost universally, like 90% of the time, said, no, I would never want a feeding tube. And in that 30 seconds, you've just saved that family 30 years of grief and self-recrimination and doubt. Any family member who's been asked, should we or shouldn't we put a feeding tube in your mom, is damned if they say yes. How could I do that to my mom and keep her alive and make her suffer? And damned if they don't. How could I let my mom die? And if they've heard from the horse's mouth, I would never want that, then we're all good. And I write that down. And the family at each conference, I remind them, because sometimes there are different family members there. And if the family members have heard that, then we can have that conversation if and when that happens, with a whole bunch more comfort and a whole bunch more certainty that we're doing the right thing for mom. And in the 30 years I've been doing this, it's not been uncommon for me to have that conversation with the family. And months later, we're in exactly that situation. Remember when we talked at the conference and we asked your mom? It's been so helpful for that. So that's the big question, feeding tube or no feeding tube. The next one is hip surgery. And I say, your mom is walking fairly well now. She's a little bit unsteady. She's using the walker. With her dementia, she's gradually going to forget how to walk. She's going to forget how to manage in the bathroom. She's going to forget how to dress. Then she's going to forget how to walk and forget how to talk and forget how to eat, all pretty much at the same time. When she forgets how to walk, she's going to go through an awkward stage where she's really unsafe, where she's falling more and more often. And there's a good chance that she might break her hip. And at that stage, breaking her hip might be the end for her. Many of my frail residents, 3/4 of them die when they break their hip, more than that, depending on how frail they are. A hip fracture is a big deal for a very frail senior, and they're probably going to die. We don't need to make this decision today, but there may come a time when your mom is too frail for major surgery, and we might choose not to do surgery on her. She's already a little bit frail now. We need to talk about hip protectors and stuff, but I want you to talk to your siblings and maybe talk to husband. Would we ever put mom through major surgery? Think about this. We don't need to make a decision today. I just need to let you know that this is coming. And at some point in the future, when mom's unsafe with her walking, we may need to make this decision. And I want you guys to have some time to think about it and chew on it together. It's not fair for me to phone you at 10 o'clock on a Thursday and say, hi, your mom's broken her hip. She's got a 75% chance of dying. What do you want us to do? Are we doing surgery or aren't we? We need to decide in this next hour. That's just not fair for families. So I had that conversation at the first care conference. The very last conversation, I got one more question for you. With your mom with her frailty, I need to talk about using the hospital and how we use the emergency department versus keeping her comfortable here. Your mom with her dementia, I have to tell you, I think for heart attacks, strokes, pneumonia, bladder infections, we do a way better job right here at Jubilee Manor of looking after your mom than in the hospital. We've got the nurse here 24/7. We've got me on the end of the phone most days of the week. We've got antibiotics. We've got Lasix. We've got morphine. We've got nitroglycerin. We can do all of this. I would much rather keep her here in a familiar environment and treat her here with comfort measures than send her to a strange hospital. We know that people with dementia do really badly when we take them out of their familiar environment. We can always use the emergency department. If your mom needs something that we can't do here, if she's fallen, if she maybe broken her leg, if she needs a cast or an x-ray or stitches or something, of course, they're going to phone me, we're going to phone you, we're going to call the ambulance, we're going to get her to emerge. I'm going to phone the emerge doc and say, I just need an x-ray and do this for me. please do that for me. Do everything you can to make her comfortable, but don't make her spend the night. I want you to send her back here. We're going to take her back here. We can make her comfortable here. Don't make her spend the night with you. We just want you to give her that comfort measure, and then we want her back. Please don't keep her. Is that okay with you? And family members, I've yet to have a family member say, no, that's a dumb idea. They all say, oh, thank goodness. I'm so glad we can do that. So those are the 3 questions that after CPR, do not resuscitate. It's the easy one. And then there's the feeding tube. And then there's the hip fracture. And then there's the how do we use the hospital. So those conversations are a big investment of your time. This is going to take 10 or 15 minutes the first time. But at every care consult, we're going to do that again. And it's only going to take 5 minutes the second time. And this is wonderful because it gets us all on the same page around values and goals of care and what we want from mom, and helps me identify that family that really does want interventions at all costs. And I need to write that. It's very clear that some families want a bunch of stuff, and I better know that in advance. And it also introduces the palliative comfort care approach right at the beginning. We're going to make mom comfortable. We can do that right here. Your mom can live right to her last day right here. So that hip fracture conversation is going to be repeated at every care conference if they're here for a while. More often we do it at the first conference, and sometime in that first year they're losing their walking already. And we have that conversation again. Mom is falling more often, and we're worried, and we're doing hip protectors, and we've got a fall alarm, and we've got the fall mats. And by the way, if she fell and broke her hip, do we think we should do surgery or not? And usually as the resident's frailty goes along, they were uncertain at the beginning, but as they see how frail mom is and how she's sleeping more and not eating as well and much sicker and spending much more time in bed and sleeping more, almost universally by the time they're losing walking, they're saying, I don't think mom could handle major surgery. I don't think she'd get through it. And most families are telling me, I don't think we should do major surgery. This is very interesting. This has really evolved over time. With all that warm up, you've gotten them ready. They've thought about this. They've heard about this, ideally 2 or 3 different times. Then when they fall and you phone them 10 o'clock on Thursday morning and say, hi, I've got some really bad news for you. I'm really sorry, but your mom has fallen. And the nurse and I think she's broken her hip, and we need to make a decision about that. Yeah. So by the time you've had all those warm conversations, they're way readier to hear it. And they've seen it coming because you've warned them. She's falling more, I'm worried. And they've had time to get ready as a family. And that conversation is going to go way better because of all the good work you've done in advance. So now those 4 jobs, the first job, is the hip broken or isn't it broken? And if you have to send them off for an x-ray to decide that, unfortunately, that lands them in the medical system. And once they're in that machine, the machine's just going to do what the machine does best, and they're going to go to the operating room. The emerge doc is going to say, oh, broken hip. If you're an orthopedic surgeon, it's a broken hip. The orthopedic surgeon will say, book the OR. And that conversation about how frail they are, and what their quality of life is, and what their preferences are, and how quickly things have been changing in this last 3 months or 6 months, can't happen because none of those players know any of those things. And you and I and the family know all those things. So I'd like to diagnose the hip fracture here in the building if I can, and have that conversation before I send them into the machine, if I'm going to send them into it at all.
Trevor?
So, yes,
if we
please.
could jump in. Yeah, it's Ralph Jones here from Chilliwack.
Yes, hi.
Hi, we're starting a project,
Yes.
just
Tell us.
ramping it up. But one of the things we're doing is arranging an alternative route, whereby if we're not sure, a resident could go to X-ray and then come back, and we can make the decision. Called with the orthopedic. We have 4 orthopedic surgeons who are on call.
Wonderful.
We're all aware of this, and we can discuss with them. So we can cut out the emergency department because,
okay,
as you said, once you're in the emergency department, you're in the mill.
Yeah. Oftentimes they need an assessment. If the GP hasn't seen them or the nurse hasn't seen them, they've fallen, and we need to check for head injury and neck injury and do a laceration. So they might need the emergency physician to go over them.
Sure, but the majority of times you find, it can wait until the next morning until somebody comes in.
Okay.
As you know, it's very often getting up out of a wheelchair and twisting and breaking
Yes.
their leg.
Yes.
And we've had some great success as we were waiting for this program over the last 3 or 4 years. Last year, 3 or 4 residents are in a wheelchair. They stood up, twisted, broke their hip. We treated them conservatively. Now they're back in their wheelchair playing bingo and so on.
That's wonderful.
Yeah. So working out a system with the orthopods and the X-ray is what we're trying to do. We are just starting for one care home. We hope to extrapolate to all the care homes in Chilliwack.
How good are the orthopedic surgeons about the dementia trajectory or the frailty trajectory and assessing frailty and surgical risk and the harder part of dementia and quality of life?
Just great. Just great. They're a young group all trained together. They're, they really understand. I mean, you and I attended a lecture a long time ago called Death by Orthopedic Surgeon, and they're well aware of that.
Yeah. So I think we're the experts in the frailty. I think we're the ones that should be talking to family and helping the families.
Oh yeah, no, like you, I'd set this up at the first. Even people who come in very healthy, apparently, or comparatively healthy, and are walking and walking well and so on. I'll say there will come a time, just like you. I say there will come a time, and if there is a hip fracture, we have this program. We can discuss it again later, just so they're aware. And for those who are frail, we with every care conference and every opportunity, we mention this new program. So it's not a surprise.
So we're trying to decide about hip fracture. If it's obvious, if it's clearly shortened and externally rotated, then even an inexperienced nurse can say, gee, it's much shorter than the other leg and it's turned outwards and it hurts like hell when we move them. That's a hip fracture and we don't need to go to the hospital for an x-ray. It's not always that clear cut. And sometimes I need to come in and say, okay, make them comfortable, I'm coming in. And that's another way. We can teach nurses how to give a better assessment so that, because not every doctor is going to drop everything and just come in or come in by the end of their office day. So one of the things that you can do is to assess for hip fracture is to first of all examine them, try and get the good leg down beside the other one so you can see if there is a leg length discrepancy. Look and see if it's externally rotated. Then you can stand them up. I'm standing up, sorry. You're not going to stand them up.
Yeah.
Oh, somehow you've gotten muted there, Trevor.
Got muted. Okay. So the patient is lying in the bed. Get the nurse to gently lift up their good leg. They're very apprehensive about the sore leg. So we're going to do it on the good leg first. You're going to pick up their heel on this side and behind their knee on this side. You're going to gently flex their hip up on the good side, slowly, 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 till they're flexed to 90 degrees. And then you're going to wiggle their foot in and out. You're internally and externally rotating. What we're doing is, if this is the acetabulum and this is the head of the femur, I'm rotating that femur around. And if they let you do that, then you put your shoulder onto their knee, compress their knee downwards, and waggle their foot in and out like that. And if you can compress their femur down into the acetabulum and grind it back and forth like that, and they let you do that, they're guaranteed not to be broken. So that's the acid test. Lots of residents won't let you do that because when they fell, they bruised their gluteus muscles and they might not be broken. So you might take a long time. You're doing this on the good leg first, and then you do it on the sore leg. You bring them up very slowly, and it might take a full minute to get up. But if they let you keep going, and it's not too bad, you can flex them all the way up to 90 degrees. Even with a fracture, sometimes they'll let you come to 90. And then you put your pressure on gently with the pressure with your shoulder, and then wiggle their foot in and out, and you're grinding away. And you're going to decide based on whether they allow you to do that and how much pain there is, if there's a fracture there. And this is where we get into the details, because it's possible to have a fracture that's not displaced like this. If it's displaced like this, they won't let you even pick their leg off. You won't flex their leg at all. They won't let you move it. It's way too painful. But you can have an impacted fracture where the bones are crushed inwards like this in the femoral neck. And they will often let you bring them up to 90 degrees and push on them a little and wiggle. But I'm pretty sure they've got an impacted fracture. They don't have a displaced fracture, but they may have an impacted one. So first of all, can you flex them to 90? Do they have pain? If they've got external rotation and shortening, they're broken for sure. If you bring them up and they won't come up at all, they won't flex at all, they're probably broken. If you can bring them up to 90 and they're moderately tender, they may have an impacted fracture. If you can bring them up to 90 and push down with all your body weight and wiggle their foot in and out, they most definitely don't have a fracture, and that's positive. So a couple of the other things that I want to mention is that sometimes the exam is entirely negative and they don't have a broken hip. Both hips are fine, but they still won't weight bear. And you get them to stand up and they're sore on this hip, and they'll absolutely lift that leg off the ground, no problem, standing on their good leg. You get them to stand on their sore leg and they won't pick that other foot up off the ground. They try, but they just can't do it. They cannot weight bear on this side. And what's happening there quite often is that they have a symphysis pubis fracture, a pubic ramus fracture. Your symphysis pubis is right here. You can all just put your hands on your symphysis pubis and push for a second. Everybody get your symphysis pubis. Now move laterally. Just off of the symphysis pubis, you've got the two pubic rami, and they look like this. They have an upper and a lower pubic ramus, and they join at the symphysis pubis, and they break right here, right beside the pubic ramus. So you're going to put your fingers on your symphysis pubis and then walk sideways and go up on top of the bone there. And right there, you're on your pubic ramus. And if you touch on one side and they hit the roof, and then you go over to the other side and it doesn't hurt at all, and you come back to the sore side and they definitely hit the roof every time you touch there, they've got a pubic ramus fracture. And the pubic ramus fractures are really good because they uniformly heal really well. I've never had anybody die of a pubic ramus fracture. They all heal in 4 to 6 weeks of bed rest. Basically, you make them comfortable. And the tough ones are trying to walk at 3 weeks, 4 weeks, but everybody starts walking by 6 weeks. Yeah. So symphysis pubis fracture or pubic ramus fracture, you don't even need an x-ray for it. It's a clinical diagnosis most of the time. Sometimes the patient won't let you examine them and it's not really clear what's going on. If their hips are fine, you can leave them in bed and decide clinically. If they're still not walking 2 weeks later, they've got a pubic ramus fracture. If they get up and walk a week or two later, then it was just a sprain. They were just bruised and tender. So the only other thing I would mention is if you've got shortening and external rotation, I got burned a couple of times because what I didn't notice is that they had a scar on the side of their hip and they had actually had a previous hemiarthroplasty from their last fracture, and they were shortened and externally rotated all the time. And they've been that way since their last surgery. So if you examine their hip, check for a scar because they may have shortening and external rotation from a previous fracture. That's a rare one. Yeah. Okay. So if they've got a hardware in there, if they've got a hemiarthroplasty, they can break around the hardware. That's called a periprosthetic fracture. And those are almost all managed conservatively. You probably are going to wind up getting an x-ray for that. And the orthopedic surgeon is going to say non-weight bearing for 6 to 8 weeks. And those do really well. Those do better than a displaced fracture. They're similar to an impacted femoral neck fracture in that sense. So those are the x-ray may be wanted if you're wondering about a periprosthetic fracture, or you can't decide about a pubic ramus fracture and the family really wants to know. But for all of these, you're gonna decide about an x-ray. Questions about diagnosing fractures with or without x-ray? Let's talk about this. What do you guys need to know?
Hi, it's Laura Bell from Courtney. I need to know where this is all written down so I'll remember it.
I'm going to send you my speaking notes. They're not very tidy. There are lots of typos. I'm going to clean them up and send them to Jessica, and she can send them to you guys. Yes, it's all written down, and I'll
Thank you.
send it out. I'll do that tonight. Jessica, oh, now I promise. Now I have to do it. Yes. What else?
There's some comments in the chat about pain management, some concerns with pain management.
We're going to talk about that. That's task number 4 is impeccable pain and symptom management. I promise.
Okay, great.
Can we move on to
Could I ask a question?
please?
You were talking about you training your nurses to examine. So like I say, if this happens at 2 o'clock in the morning and then they call you, you've actually worked with your nurses enough to feel comfortable with their clinical skills then. Is that what you're doing?
So let's talk about that. That's a great question. So we have so many contract nurses and none of them have any experience in long-term care. In our owned and operated facilities, our health authority facilities, we've got great nursing. In our P3 facilities, many of the nurses are contract nurses, and this whole palliative care and assessing things, that there's a steep learning curve for a lot of these nurses. So it used to be that we could do this reliably, and that's much more difficult in these COVID times with unstable staffing and less capable nurses. You may have a very experienced RN who can do this. We teach the nurses how to do this. Most of the time, if it's uncertain, I go in and see the resident, not right away. I can go within hours or first thing in the morning, and then I assess, and I make sure that I drag as many nurses into the room for the assessment as possible. There's no better way to learn how to diagnose a hip fracture than to see a hip fracture and see Dr. Janz wiggling their hip and poking and saying, look, check for this, check for this. So this is a wonderful teaching moment. If you have to go in, don't waste it. Make sure that you've got as many nurses in the room as possible so they can all see what it takes to diagnose a hip fracture. And sometimes they wind up going to the emergency department and I get the x-ray and then I come in. That's the other thing I wanted to talk to Ralph about, is if they have to go to the hospital for the x-ray, then meeting the family member at the hospital, and in my world, in a small town BC, I meet them in the emergency department. We look at the x-ray together, and then we have that big conversation with the resident and the family member all together right at that point. And that's a good way to do this. And oftentimes we're calling daughter on the cell, daughter from Toronto is on the cell, and we're all on speakerphone and we're all asking dad, do you think we should do surgery on you? Do you think you've got enough to get through this? So those conversations can sometimes happen in a bunch of different settings. Yeah. Did I answer your question?
Yeah, you have the same experience I have. Thanks.
Yeah, it's challenging. You can't always count on the nurses. Sometimes it's a trip in. And if the resident is quite late in their dementia trajectory or is very frail, I'm motivated to go to the building and do that so that I don't have to send them to emerge, because just the sling and lifting them onto the ambulance and the drive into the hospital and on and off the x-ray table to say, we're not going to operate, let's make you comfortable. I would love to save the resident all of that suffering. They're frail, they're old. Back and forth to the hospital is a big deal for them. And if I can come and examine and I'm clear based on my exam that they're broken, then I can have that conversation with the family without having to put them through all of that. So I love saving them that discomfort if I can. Yeah. Other questions about diagnosing before we move on to assessing, should we offer surgery or not?
Trevor, I'll just jump in because you're asking me, Ralph here again, a question. That's one of the things that we're looking at with our project, is the difficulty in ramping up your ideas, and we've heard your wonderful lectures a few times, to a large town of 100,000 people with EHS systems that are frankly crap. We never know exactly when the resident's going to get transferred, you know, and EHS are the worst ever communicators or handlers of documents you've ever seen. So again, of those people I mentioned, the 3 you did well, I'm pretty sure that 2 of them never went to the hospital. It was so damn obvious that we just treated them. And if we do, the plan is actually when they go to the hospital, they'll go directly to X-ray, and then there's a communication with the orthopod on call. And it's all with the relatives and the relatives as well. It could be just the relatives. Yes, it is a hip fracture, and we don't want to operate. No, we don't even bother the orthopod on call. So that's what we plan to do. But doing this when you have up to 20, so sometimes 25 GPs attending the care home, when the EHS is probably the worst service in the world, is more difficult. How do you systematize that? And that's what Dr. Dara Donnelly, who's heading up this project, is looking at. How can we make this idiot-proof? Yeah.
In the city? Absolutely. In small towns, I've got a personal relationship with all my colleagues in the emergency department. I was in the emergency department for 30 years. I phone them and say, look, this is what I want. Can you do that? And they all say, good. In an ideal world, direct personal communication between the sending physician and the orthopod or the emerge doc, that's the gold standard.
We have about 8 emerge physicians. And if you speak to one, penny to a pound of fertilizer, that's not the one who'll see the resident.
Right.
In circumstances when I really want a great ER opinion, I pull up the ER rotor, and I might even delay by a day to send somebody in when I know there's an emerge physician I know and who can be reasoned with, because some of them you can't.
Right. So you're picking your emerge doc.
Yeah.
So let's talk about deciding surgical risk, because there are a bunch of indicators about how frail you are and whether your risk goes up. And I'm going to give you a shopping list, and I'm going to share this list with you afterwards. But the list is cumulative. The more of these things you have, the higher your mortality. And I quote numbers anywhere from 50 to 90% on mortality, depending on how many things you have from this list. So let's start with the medical diagnoses. Anybody who's got end-stage disease, be that heart, kidneys, lung, is at very high risk. So look for congestive failure. I mean, just hypertension and ischemic disease, coronary artery disease and stuff. But if they've got congestive failure, and how much Lasix are they on, or how low is their ejection fraction, or how many symptoms they've got despite maximal therapy. If you're on more than 40 or more of Lasix a day, and the spironolactone and the bisoprolol, and your ejection fraction is less than 35, and you've got symptoms at rest with edema and shortness of breath and chest pain, and you're on oxygen, we're done. The conversation's over. You're not a surgical candidate of any way, shape, or form. But if you've got milder failure, but you've got fatigue and you're mostly in your chair or bed bound, you're frail enough based on your congestive failure. We probably shouldn't be doing surgery. If you've got mild congestive failure, but you've also got COPD, and again, end-stage COPD, you're on maximal puffers, you may be on steroids. If you're on home oxygen, if you've got shortness of breath at rest, if you've got recurrent infections, all those are indicators that you're not a good surgical candidate. Same thing for kidney disease. If you've got end-stage chronic renal failure, if your GFR is less than 30, if you've got anemia, if you've got wasting, if you've got fluid retention, any of those things tell me that you're not going to do well with surgery. If you've got diabetes, and the more severe the diabetes and the more the complications, the more seriously I take that. If you've got hypertension, the coronary artery disease, the peripheral vascular disease, if you've been on prednisone for any period of time, for your rheumatoid, for your polymyalgia rheumatica, for COPD, for SLE, anybody who's been on steroids for a long time is at much higher surgical risk. And the other piece of this is weight loss. That's one of the biggest things. If you've got congestive failure or COPD and you're still portly, you're more durable. But people who've started to lose weight because of their chronic disease, they're on this part of the curve now. And it's really important to identify those people who've got late stage disease with symptoms despite maximal therapy, and they're now losing weight because they're losing lean muscle mass. And those are the ones who are going to do really poorly. Important, if they've had previous surgery, if they've had a history of post-op delirium, or they took a long time to recover from a previous surgery, those are things you need to know about. And then frailty. We've got the Rockwood scale. We can pull up the Rockwood scale but most of us have seen this. If you've got severe frailty or very severe frailty, a severe frailty is a 7, and you're unsafe walking, you need help with the basic ADLs, you may have some incontinence, you may have middle stage dementia. That's a significant risk factor. And if you've also got other comorbidities, that would tip me away from surgery. If you've got very severe frailty, if you're a lift transfer, you're bed or chair bound, you're total carrier incontinent, you're not a surgical candidate, and that makes it really easy. Yeah. There's the Rockwood's frailty scale. So 6 and you're moderate, yes, you could still manage surgery. But if you had other comorbidities, if it was just your frailty and there was nothing else, and you'd walked a lot for a long time, you might do very well with the surgery. But if you've got that frailty plus some congestive failure, plus some diabetes, plus some dementia, I don't think you're going to do well. And anybody 7 or 8 probably shouldn't have surgery. Yeah. David Brooks got his hand up. David, jump in. You're muted.
I know. I wondered if you had thought about creating the Janz late life predictive scale.
No, I hadn't. Should I?
Yes, for nursing, for RAI, right, data, for a way of, in the way a palliative predictive scale will predict, what your lifespan is going to be, the one that was developed at the palliative unit in Victoria. I think the Trevor Janz late life predictive scale for surviving fractured hip would be a great service to British Columbia, Trevor. You've got the list in front of you, right? Figure out a way to score it up in a way that gives us a predictive scale, so we can say to families, if your loved one has any number of these risk factors, here's what's going to happen when they fall and break their hip. They're not going to make it.
Wow.
Because Trevor Janz says so.
I'm hearing you. We can think about it. To be discussed further. Let's keep going. Thank you. I'll take that as a compliment. So the other things that I need to know from the nurse, so that's the medical stuff. The things that I want to know on the phone with the nurse is, have they declined? How quickly are they declining? Has there been a recent increase in their confusion? Have they lost more abilities? Is their dementia progressing? And this is a big one. How much of the day are they sleeping? What percentage of the day are they sleeping? And if they're sleeping more than 50% of the day, that's very significant. And if they've started sleeping 60, 70% of the day, we don't need to do surgery. This is a patient who's in that steep part of the curve, and we really, really shouldn't be doing things for them. Yeah. The other thing besides sleeping more of the day is how interested they are in eating. And people who are scarfing down food and maintaining their weight really well are likely to do well with surgery. And people who are indifferent about eating, they're less interested, they're eating dessert, but they're not eating their main course. If their weight is going down, if at any stage they're refusing meds or refusing meals, skipping meals sometimes because they don't want them, sleeping through meals, staying in bed for days at a time, all of those are significant predictors of frailty. You really want to know about those. And now I'm ready with all that in my hand to say, this is a person who's likely to survive surgery and I should offer that. Or this is a person who should never be offered surgery and I want to tell family I think it's a bad idea, or it's somewhere in the middle. And armed with that information, it's time to have the conversation with family, because now we've got the third job. The first job was, are they broken or not? The second job is, how frail are they? Now the third job is, let's go talk to the family. And because you've done such a wonderful job of warming the family up to this, you've talked to them lots about this. They're not surprised when this phone call comes. So now here we go. It's Thursday, it's 10 o'clock. I'm really sorry about your mom's fracture. I'm really sorry. Sorry, I just had to close the door for background noise. I'm really sorry that she's broken her hip, and I'm quite worried. At 83 years of age, with all your mom's frailty and her dementia, I think she's got about an 80% chance of dying within this next week. And then let that sink in. This is very conscious. I've set the stage. And I said, I'm sorry, but, and then I used the dying word. And we use a lot of euphemisms in long-term care. And very often we think we're being really clear with families about your mom has not got much time left to live. And families in their denial can miss that. They cannot hear that. It's amazing what they can't hear because they don't want to. I use the D word in this phone call. I'm worried that your mom may die in this next week. And we've got some choices to make. And I let that sink in. And that's really important. Use the dying word. I'm saying there's a possibility that your mom might die in this next week or this month. And that gets their attention. And then we talk about the hip fracture and we talk about the risks. I'm really concerned. Hip fracture at 82 is a big deal. Many people don't survive. I'm worried about your mom. She's quite frail between her heart and her shortness of breath and her blood pressure and her diabetes. I'm worried that she might not survive. And talking to the nurse just now, what I've heard is that she's not eating as well as she did before, and she's sleeping at least half of the day. I wanted to let you know that major surgery, we need to decide about this, but I'm worried that it could be quite hard for her. Because of her frailty, she's at high risk of complications, heart attack, stroke, blood clot, pneumonia. She could have a post-op delirium where she gets very restless. She's seeing scary things. She's trying to climb out of bed. She's pulling out her IV. She's tearing out her catheter. She won't keep her oxygen on. This is a terrifying thing for her. And many seniors, even if they get through the surgery and the delirium, they stop eating, they stop drinking, and they slip away within the week, 2 weeks. And I don't want her to die in a strange place. If your mom's going to die, I don't want her to be in a 4-bed hospital ward with no privacy and no quality of life and no peace, with nurses who don't even know who she is or what she needs. I think we could do a really good job of making your mom comfortable right here. So if you choose not to have surgery, I'm very confident that we can keep her right here at Jubilee Manor and control her pain and make her comfortable. It's important that if she keeps eating and drinking, she can survive. Not everybody dies from a hip fracture. And if she wants to stick around, and if she keeps eating and drinking, she can get through this. It happens. My experience is that most people don't. And they stop eating and they stop drinking. We make them comfortable and they slip away very peacefully, very quietly. We make them comfortable. They get sleepier and sleepier. They barely open their eyes when we turn them and change them. And they just stop breathing. They go to sleep. This is can be a very peaceful and comfortable way for your mom to leave her body at this stage. Sometimes it's not as clear as that. And if the resident is cognitively intact or more cognitively intact and able to have the conversation, I'm not talking around the resident with family member and making a decision without the resident. I'm right there in front of the resident and we're having this conversation with the resident. And that conversation looks very different because we need to talk about quality of life with the resident and ask them what their preferences are. So the quality of life question, we talked about, oh, is there a question there?
I think it was just a bit of feedback. Keep going.
Okay. So if they've got significant dementia or other reasons for poor quality of life, we might have already talked about that. But if they're cognitively intact, we need to find out from the resident if they want to keep going or not. And I love to have this conversation with the resident and family members present. I had this conversation with the resident. I went up to Jubilee Manor, examined, and then got brother and sister on the phone, and brother was in St. Kitts on a tropical vacation in the Caribbean, and sister was on a cruise ship, and they were able to patch a line through to get both of them together with dad, Bud, right there in the bed. And I asked Dad, I explained to him the situation and said, you know, this is serious, you might not survive. Do you think you can do this? Do you have enough gas left in your tank to get through major surgery? He said, no, I don't think I want to do major surgery. Yeah. And we can often have the question about quality of life. Do you want to stick around? And the best quality of life question that I know for family members or for residents is, are you having any fun? And the resident stops and thinks about it. And sometimes they say, yeah, football game, apple pie, family coming, yeah. Very often they, yeah, right. Are you kidding? Look at me. Do you think this is fun? Do you think I'm having any fun here? And that's key. If they're not having any fun, the chance of them sticking around when they've got a chance to take this door out, they're going to stop eating and drinking. They're the ones who are not going to do this. Sometimes dad's not able to speak for himself, and we have to talk to the family about quality of life. And I ask, is your dad having any fun? Is he enjoying any part of this? And sometimes they can't really say for sure. Would he ever have wanted to live like this? He's in the wheelchair, he's incontinent pretty much all the time. He only recognizes you some of the time. He's needing more feeding. Would he have ever wanted to live like this? One technique that's really effective if you've got a family that just can't really understand what's going on or can't really decide clearly, or some family members are pro and some are against. One really useful trick is to say, I want you to think about your dad way back 20, 30 years ago when he was at the top of his game, when he was in his prime, when he was the master of his life, when he was doing life on his terms, living it his way. If your dad at the top of his game was to see himself now in the wheelchair, needing help with feeding, needing help getting his pants on, needing help to wipe his bum, if he's continent at all, would he have said, yes, I want that to last as long as possible? Or would he have said, I would never want to live like that. The sooner that would be over, the better it would be for me. And you see people pause, they stop, and their eyes stop seeing me, and they're going inside, and they're listening to their dad, they're picturing their dad. They actually hear his voice. And 10 seconds later, their eyes come back into focus. They look at me and they say, Dad would never want to live like this. He would say, take me up behind the barn and shoot me. And 90% of the time when I ask that question, the answer is, Dad would never want to live like this. And that's the crucial piece here. I think this is the most important part of the conversation is, what's Dad's quality of life? Is he having any fun? And what are his preferences? If he could speak for himself, if he can, let's ask him. And if he can't speak for himself, try and get the family, not to say what they want. You can't let my father die. He has to have surgery. That's what the family wants. I want them to be able to speak for their father and let their father, they're the expert in who their father was. What would your father have wanted? And that's one of the ways that you can help them come to that. And that's tremendously therapeutic. It's going to help them enormously with their grieving process. It's going to help them so much to come to terms with, Dad would never have, he would have hated this. And if he goes, this will actually be a good thing for him. And it reframes the whole dying experience from you can't let my father die to it's time to say goodbye to dad. So go for the quality of life and preferences thing if you can. If nothing else is clear, ask, what would dad have wanted? Was dad having any fun? Let's stop for questions about this, because this is the biggest piece. This is the money. This is why we're all here tonight, is how to have these conversations with families. So talk to me. Tell me what concerns you have. What about this, Dr. Janz? What about the family that insists on everything? Ask me those questions. Can we go back to the gallery so we can see each other? Thank you. That's lovely. Okay. That looks like a question, David. David Brooke?
Sorry, I was just playing with my pen.
Oh,
You know, I think you've really hit on something terribly important here. You used the word trauma informed for families, and it's the 14% of families who have some disorder and that's blocked them from getting to a place of oneness, recognition, acceptance, and forgiveness. Those are words I use when I talk to families. It's not so much a question here as it is a comment. And as you say, you can prepare them by adopting a parlance, I think, that we can all use. You use the word comfort care. I use the word aggressive comfort care, because I think comfort care may connote a certain laissez or passivity that I don't want. This is an active process that we're engaged in with actively, aggressively comforting people. The second thing I use is the word late life as opposed to frailty. I think late life connotes it's late and you should be getting ready to do something. And I think that's the where this whole business where clergy people used to help families get to a place of recognition, acceptance, and forgiveness that we're increasingly having to do. And the thing you've really hit on that struck me is absolution, absolving families of their anger, their fear, their guilt, right? And the anger, of course, is projected fear, which is natural. But ascertaining and judging which families you can work with, the 86% versus the 14% that we always get stuck with, is really the challenge when you have trauma-informed families. So I won't say any more than that now.
so absolutely. And the 14% are the ones that we need. My natural reaction to those 14% is to back away and to avoid communication with them. And I need to do exactly the opposite. I need to hyper communicate. I need to lean in. I need to move in. I have to get on the same page. I have to say, your dad's quality of life is really important to me. I don't want your dad to suffer. It's really important to me that your dad not suffer. I don't want to see him get stuff done to him that's not good for him, that's going to make things worse for him. We need to understand together how we can give him the best possible quality of life with the little bit of time that he's got left, because we're really at end of life here. We're in the last chapter. We don't have much time left, and how are we going to spend that in the wisest possible way? So David, thank you for those wonderful words. Yeah.
Can I ask a question?
James, please jump in.
I work in a town like Chilliwack, over 100,000, and we got quite a few docs who work in long-term care. One of the problems I have, in a sense, is that I have my sort of pattern of practice, and then we take call, right?
Yes.
And sometimes I've run into issues where when I walk into a situation, I say, well, whoa, you know, if you're on call, sometimes you're getting called into these situations where someone may have fallen and clinically broken their hip, and you're saying, as you went through it, they're too frail, they got too many medical conditions, but the doctor who you're covering has never gone through them, and the family's saying send them to the hospital. And so what would you do in that case when, in a sense, you're walking in sort of cold and you're being out and you're clinically saying they should never go to the hospital, but the whole system is set up to send them to the hospital?
James, how is that conversation going to happen? Are you going to talk on the phone with the family? Is there any chance
Oh,
that you
I would be going in.
Okay.
I mean, if they, especially in my town, if I suspected the patient has a fractured hip, I'm walking in, I'm going to be I'll be examining the patient. I'll be the one who's basically have to take the bull by the horns and talk to at least if the patient is awake, I'll talk to the patient. I have to determine if the patient has got ability to even understand what I'm saying, and then try to find family members. That's my philosophy. But what I'm getting at is that that's my philosophy.
Yes.
Like I say, this patient and the family have never had these discussions before, and I'm bringing them up at the point of crisis.
Yes. Yes. So we're working on spreading the love. We're working on spreading that culture of early conversations, early and often conversations about what's coming as you get closer to end of life. How do we do this in the right way? How do we avoid burdensome medical interventions? How do we do the right things for your mom and do fewer of the wrong things? Yeah, we're really good at doing too much of the wrong things for frail seniors, unfortunately. So we've got a lot of work to do in that department. And the more people we model that for, the more times we have that conversation in the presence of other people who say, holy smokes, we could have that conversation. It's possible to talk to families and understand their values and understand the quality of life involved and understand what the implications are of some of the choices we're making. Those are all important things for us to teach family practice residents and our fellow physicians. Yeah. Anybody else with bright ideas about how we move the world forward?
It's Ralph again. Sorry, I had my hand up. Just through to Jamie there. You can't just start doing this on your own. To change the culture is difficult. It requires project management. We started in a small way, showing the successes in 1 or 2 of our 7 care homes. And then it's going to be a series of meetings, CMEs, as you say, demonstrating the success stories and the problems. So you got to have everybody on board. You can't just say, oh, I think I'm going to start this next week. I'm not going to send anybody with a hip fracture to hospital. You know, it's not going to work when you're in a system that will crush you. To change the system, you need to do the basic work on system change. And the QI approach is ideal for this. This is what we're doing.
I'm wondering if I could call on Stephanie Hood. Stephanie's a hospitalist and emergency doctor. I don't know if you're close and can answer. Stephanie, if you're still with us. And
I am.
You're unmuted. So explain your role to the people on the call and tell me how this is landing for you as a hospitalist and emerge doc.
Well, I'm very happy to hear that conversation, and I've had a chance to listen to you talking about that in the past, Trevor. I did, as I put in the chat, I also went to another hospitalist presentation in this fall, and they were really relaying the same ideas, supported by a study. There was 2 studies they presented, but one done in, I believe, Denmark. And what was fascinating was we might feel, we don't know as hospitalists at least, what happens if we don't do surgery on those patients. And they really had good data about, mortality, satisfaction from family, pain management, etc. And I guess, we could potentially spread that word, at least to our hospitalist group. I was even thinking, as we've communicated, to present that to our emerge and orthopedic surgeon to say, if that conversation for whatever reason did not happen, or the system, I totally understand how the system pushes people towards the hospital, then maybe it's also a good time as a safeguard, kind of a last resort for the people in the hospital to have those conversations. Often, the frail people have comorbidities. So as hospitalists, we are often involved, and they often don't get to the OR right away. And in the OR right away. So, we could all be involved, but I wish, really wish that we make people more aware of this and also more comfortable with saying, potentially it's preferable to not do surgery on your loved ones. And we need, and the reason I've put the data there is I think we feel a little bit uncomfortable. It's harder not to act often in medicine than to act.
Yes, it's hard. These are courageous conversations, yeah, for us to launch into. Absolutely.
So potentially, I'd love to have you talk to our group, Trevor, at one point with more of a hospitalist, like acute care lens.
Absolutely, that would be lovely. We just need to go out there and have these conversations. The good news is we've been talking about hip fractures for when I first presented this at a Providence long-term care conference, maybe 15, I don't know, 20 years ago. I felt like I was going to be pelted with rotten tomatoes for this heretical suggestion of not doing surgery on a frail senior with a broken hip. How could you let her die with a broken hip? It was scary for me to stand up there and say that. But here we are having this conversation provincially, and Ralph's got a pilot project, and you guys have got one-pagers done by your lovely nurse practitioner who's done wonderful work. So it's coming. The world is moving. I'm looking at the time, and I've got 16 minutes left, 18 minutes left to talk about pain and symptom management. And we haven't even started on that yet. And I promised to do that. So can we jump into that now?
I think we've got a question there. Kat Ryan has her hand up.
Yes.
Hi, Trevor. I'll try to speak quickly. I'll make one hopeful comment that I've noticed in the last year that orthopedic surgeons have been writing in some of their consult notes, risks and benefits of surgery explained to families. So that's promising. When you jump into this next section, my big question is how to go about preparing the care team, the nurses, the care aides, OT, et cetera, to deal with a hip fracture on site. Because it's easy for us to say, do this and that, but what's the process around making sure you actually will be able to keep them comfortable?
That's our job. Let's jump into that. Catherine, I love your handout and you're doing great work. So the very first piece, as soon as you hear that they've got a hip fracture, is to get them some analgesia. They've just broken their bone and we need to get some pain medication in. We're going to do something painful. We're going to put them in a lift and get them up off the floor. I want your nurses to be able to administer pain medication right away all the time, even if it's 2 o'clock in the morning. I'm going to say another heretical thing. In my world, as a medical director, working really closely with 2 facilities and managing all of the residents in each of those buildings, I have pre-signed palliative orders for all of the residents so that the nurses' palliative orders are nurse initiated. If the nurse at 2 o'clock in the morning has somebody who's on the ground with a probable hip fracture, they can give morphine, even if I don't answer the phone. And the idea here is that the last thing I want is for your mother to fall and break her hip at 9 o'clock at night and for no physician to answer the phone and for her to not to get analgesia until the next morning. And in small towns, it's common enough if the nurse won't reach the physician on call, she'll call the emerge doc and the emerge doc will cover with orders. But in the big city, that doesn't happen. And without a doctor's order, your nurses can't order pain medications. So if you're a medical director, or if you're a director of care on this call, can you work with your doctors such that your nurses in exceptional circumstances can make sure that the patient can get analgesia, no matter whether the doctor answers the phone or not? So that's my plug. I won't take more time with that. I really want analgesia for residents when we need it, whether the doctor answers the phone or not. So if you've got a probable hip fracture, I'm thinking about, I need to make the diagnosis. And so I come in, we get the diagnosis. We have the conversation with family. Often I need a Foley catheter. If they're going to eat and drink and they're going to be in a brief and they can't get up on a toilet for sure, and changing their brief is a big deal. If I have to change their brief every 4 hours with a fractured hip, that's not going to work very well. So I want a Foley catheter. If I think they're going to die in the next 3 days, they're going to stop eating and drinking and slip away, we don't need one. But if I'm not sure whether they're going to live or not, I want a Foley catheter. And if we do that in that first hour or two, we can still move them. But by the time they've had a hip fracture for 4 or 5 hours, all their muscles seize up. And if you try and spread their legs apart to put a catheter in, it's so painful then they've seized right up. It's terrible. So the time to do it is early. Now, immobilization. I learned how to immobilize broken legs from the ambulance people. And the ambulance people put a pillow in between their knees, and then they have elastic straps, Velcro straps about this wide by about this long, that they wrap around, one above the knees and one below the knees, and just lock the two. We've got someone needs to mute. Yeah, there we go. So locking the legs together, splinting the injured leg against the good leg is really simple. Put a pillow between their knees so that their knees and ankles, bony prominences don't create pressure spots. And then if you've just got wide tensor bandages, use wide tensor bandages above the knees and below the knees to immobilize their legs. And most people with a hip fracture don't want to move their legs at all. So if you brace the two of them, it's possible for you to log roll the patient so that you can roll them one way and change the brief and then roll them the other. They need their brief changed only for bowel movements if you've got a Foley catheter in, and those are going to be very infrequent. They need to be rocked back and forth for repositioning to prevent pressure sores every couple of hours. And you only need to just tilt them 15 degrees with a little bolster under one side, and then 15 degrees the other way with a little bolster. And that can be done really easily. So you don't have to move them much at all. And if you're not changing their brief frequently for urination, you really can get them wrapped up, get them immobilized. And if they're not moving, the pain control is really easy. It's only when we're providing care and moving that hip fracture around with a broken bone that the pain is the issue. You're always going to need subcutaneous opiates. I've tried to do this with oral medication, but I always get into trouble. And with the nurses not being comfortable with drug titration, you really need to have a well-oiled machine in working with your nurses. You and the nurses have to have all of the kinks worked out so that you can do really good pain titration. And the nurses, if they're experienced, you can teach them and support them to titrate effectively. But you're only going to get good pain control if you've got experienced nurses who are empowered to make good decisions and you're readily available. So this is an intensive process for the first day or two. There are going to be a few phone calls, tweaking the dose. You need opiates, use tiny doses. I'd use usually hydromorph, 0.5 milligram, or morphine 2.5. If they're opiate naive, if they're tiny. If they've been on opiates, if they're on hydromorph 20, twice daily. If they're on MS-LON 20, twice daily, we're going to have to calculate and give them quite a bit more. So if they're not opiate naive or they're larger, they're going to need larger doses. But the idea is, I want to get quick pain control. I want to establish good control of their pain within the first 1 to 3 hours, but I don't want to kill them with an overdose. So the secret is to use multiple tiny doses and stack them one on top of the other. 2.5 of morphine, 30 to 40 minutes later, still no pain control. Another 2.5, another 2.5, another 2.5, and just keep going until they've got good pain control. And that dose would be 0.25 if they're opiate naive, or 0.5 of hydromorph if they've already been on opiates. And teach the nurses to stack the doses. Just keep giving them 0.25 until their pain is adequately controlled, and watch their blood pressure. Once you've got that, within the first 2-3 hours, you've got good pain control. At 3 or 4 hours, stop and add up how much opiate it's taken for you to get good pain control. And if it's taken you to 3 doses of 0.5 of hydromorphone to get good pain control, you may need 1 or 1.5 of hydromorph every 3 or 4 hours. But I want them to get, once you've established good pain control, I want them to get subcutaneous analgesia every 4 hours, whether we think they need it or not. I do not want to withhold doses and get them have a pain crisis and then chase them again and get good pain control and then not give any. I don't want to wait until they've got pain for us to treat them. I want to treat them every 4 hours. And the trick is to, as quickly as possible, find out what the right dose of opiate for them. So tiny doses, stack them till you get good pain control. At 3 or 4 hours, figure out how much it's going to take every 4 hours to do this. Make a guess at that and give that every 4 hours. If you've given them too much, they'll be passed out. You won't be able to wake them, and 6 hours later, they'll finally start waking up. We need to turn that down. You've given them too much. If the dose only lasts 1 or 2 hours and the pain is coming back at less than 4 hours, you haven't given them enough, and you need to bump the dose up. Just give them more. If you were giving them 1 of hydromorphone and they were good at first, but 2 hours later, 3 hours later, they're moaning and rocking, give them 1.5 right then. Don't make them wait for 4 hours for their next dose. Give them more medication, turn up the dose and give it right away to get good pain control. And this means that the nurses are going to have to do assessments. They can't just say, oh, he's one milligram every 4 hours. Every time they give a shot, they need to go back and look at the resident an hour later to see if they've got good pain control, 2 or 3 hours later to see if it's wearing off. So they have to be able to do that, and they have to be empowered to do that and supported and reinforced. If you've got a director of care who's confident about this, she can mentor them, or you might be doing that yourself. Start constipation medication the very first day. Don't get behind on that one. Time your medication such that all care happens half an hour to an hour after they got their last shot. If we know we're going to be turning or repositioning the resident, the nurse and the care aides need to work together. She's just had his shot. You can reposition in half an hour. Don't move them when they're next due for a pain shot. Move them half an hour or an hour after they've had their last pain shot. That would be open. Questions about titrating the dose? How does that sound? Do you think your nurses can handle that? There's a hand up. Yes.
Hi, Trevor. It's Dale Nickel.
Hi, Dale.
You were using sufentanil at one time, were you not?
So that's for incident pain. Sufentanils are really, for those who are not med it, it's a crazy rapid acting opiate that's got a very short half-life. And sufentanil is wonderful for incident pain. You have to have nurses who know what they're doing, and you have to work closely with them. But the story, they do this lots of the time in hospice palliative care and in burn units. Sufentanil is 1,000 or 10,000 times more potent than morphine. We give it in microgram doses. It comes in a vial that's 50 micrograms. And for somebody who's opiate naive, you're going to give them 12.5 under the tongue, or you can put a little sprayer on it and stick it in their nose and go squirt. The intranasal is what we use in pediatrics in the emergency department. And it works within 5 or 10 minutes, 5 minutes, and lasts for 15 or 20 minutes. And then it's gone. And if you've got somebody that you need to do a dressing change on and you give them subcutaneous morphine, it's going to take a lot to control their pain for the dressing change. And as soon as they're motionless and they're not moved anymore, as soon as we leave them alone, they're going to be passed out for 4 hours, 5 hours, because of the morphine that you gave them that you only needed for 10 minutes, less than that, 3 minutes. And they're not going to eat, and they're not going to drink, and they're not going to survive. You put them in a coma. So sufentanil for incident pain, if they're really opiate naive and tiny, 6.25 micrograms. For most, it's 12.5. For solid guys, it's 25. For people who've been used to hydromorph cotton in large doses, you give them the whole 50 micrograms, goes in their nose or under their tongue. It's only 1 ml for the whole 50 milligrams. So it's a really tiny amount. Put it in, try not to let them swallow. 5 minutes later, 10 minutes later, you're good to go. You've got 10, 15 minutes, and then it'll wear off. Respiratory suppression is uncommon, but still happens. Do you have a bag valve mask? Gosh, I actually don't in any of my buildings, but we still use sufentanil once in a while. It takes you and the nurses working together confidently, but sufentanil can work. I don't do that for hip fractures when they're dying of hip fractures. I'm trying to find good pain control for when they're motionless in the bed. When we turn them, when we're providing care, I try and do that half an hour later. Oh, Jessica, my nurse says we do have a bag valve mask at Mountain Lake. Okay, good. Thank you, Jessica. I'm glad we do. Yeah. So I don't want to give them so much pain medication all of the time that we can do care at any time. I want enough medication when we're doing care that we can do it comfortably, but then I want them as light as possible so that they can eat or drink or interact with their family. If they're dying, time the medication doses for when family are coming. Try to have them lighter, but not in pain when the family comes so that they can talk. If they've just gotten a big dose and the family arrive and they're sleeping for 3 hours, we've missed an opportunity if they're in their last days of life. So coordinate with the family and the nurse to try and balance the timing. You want to use the least effective dose, the lowest possible dose that provides adequate pain control. Yeah. More questions about that? Another hand raised. Yes. Tareen, you're fun. Yes, please, Tareen.
Hi, thank you for such a nice presentation. So my question is regarding two things. One is for the severe dementia patient, many times nurses tell that it is difficult to assess their pain. So in that case, how to titrate the dose of the pain medication? This is one question. And the other is sometimes in those patients, elderly in the long-term care, it's difficult. What I heard is difficult to give them the oral medication. So they always push you towards either the fentanyl patch or something where they don't have to go and give them the oral medications. So can you comment about that how to weigh and balance and figure out in terms of if the patient is not receptive to oral treatment, then is the fentanyl patch a good option or not?
Okay, so two questions. Assessing pain. There's a pain ad scale, pain in dementia scale, and it looks at furrowing of the brows and sweating and tachycardia and restlessness and grimacing and all those nonverbal cues. So it's absolutely possible to assess for pain in somebody who's got late dementia and who's nonverbal, and your nurses need to do that. There was a care home in the Okanagan that the pharmacy required the nurses anytime they gave a PRN pain medication to record a pain ad score. And this was a huge make work project for the nurses, except that within a week, they all got so good at doing pain ads that they could do a pain ad in 10 seconds from the door of the bedroom, which was a wonderful skill. As soon as you can go through that checklist, you can assess whether the resident's got pain or not. And we need to teach the nurses and expect them to use the tools that we've got to help with that. So the second piece is residents who are reluctant to take oral medications. For residents who are not dying of a hip fracture, we always try to use oral medications when we can. Tylenol tastes terrible, and when you crush their Tylenol and put all their pills with it, I wouldn't swallow it either. If you gave me that 4 times a day for the rest of my life, I'd say no thank you too. So I switched to oxycodone because it's tiny and it's much easier to take than the Tylenol, tiny doses of oxycodone instead of the Tylenol. Fentanyl patches have a fatal flaw. The lowest dose of fentanyl patch is 12.5, and that's equivalent to 50 milligrams of morphine a day. And most of the residents that I know that are opiate naive, that would kill them. I've got residents who are on 2.5 of oxycodone twice a day for their pain, which is the equivalent of about 7 milligrams of morphine. We can't use fentanyl patches. There is one patch, if residents really can't swallow pain medication, you can help them with the Butrans patch, B-U-T-R-A-N-S. This is buprenorphine. It's safe in that it doesn't cause respiratory depression. It's lovely that it comes in a 5, 10, and 15, and a 5 is about equivalent to 10 or 15 a day of morphine, somewhere between 5 and 15. So you can take somebody who's opiate naive and give them a Butrans patch, and it's on for 7 days. It's not cheap, it's not covered. It's $45, $55 a month for 4 patches. Families have to pay for it, but it gives dad 24/7 pain control. He's got pain control right through the night. He doesn't wake up in the morning with terrible pain. So that's one option for pain control for them. Yes? Okay. Dale, question?
Yeah, getting back to this, to the sufentanil for a moment, I've been advocating using it for incident pain with hip fractures. Generally speaking, if a person is not mobile in their beds, they're not having pain, or we use low doses of hydromorphone, and we just use the sufentanil for providing care and so on. So it sounds like we're being a little bit more adventuresome in that department than you are. We tend to use it nasally, as you suggested, and it's been quite effective, but there's been some roadblocks put in the way because people want to make sure that it's used properly. But in an informal way, just training nurses, I found it to be very effective. So I guess I'm using it more than you do. I thought you used it more, but obviously I'm incorrect.
So if you've got a stable nursing staff and you're working really effectively with them and you're confident, that's okay. And it's a very high risk medication. And you can give respiratory suppression in a heartbeat with sufentanil. You can kill people with this drug. And if you have, in my world, in my P3 facility, I'm running on contract nurses and I can't get them to do simple nursing tasks, or we're struggling with good palliative pain management. So putting sufentanil in their hands is just terrifying for me. If in the good old days when I had stable staffing and wonderful nurses and we were running like a Swiss train, that was perfect. But I live in a different world now, it seems.
I hear you. Thank you.
Yeah.
There's a question in the chat there as well from Dan Husband. What about ketamine for initial pain management?
Okay, if we thought sufentanil was edgy, now we're into emergency palliative sedation. No, I don't think I'm going there. This is procedural sedation, and we don't have IVs in my building. We don't have nurses. Man, I'm lucky if the patient gets care in a day. I'm sorry. No, I'm not going to ketamine, I promise. We can do that in the emergency department, but no, not here. Thank you. Okay. Other questions, other comments? Can I just, oh, Lyle. Yes, please, Shyla.
Hi, everyone. I'm a LPN in long-term care. One of the roadblocks we seem to have is our doctors not trusting us and waiting way too long to treat pain.
Yep.
Or starting too tiny and not giving us enough of a range that we can make changes in the middle of the night when our patient's status changes. Any of you docs have any comments on ways that we can, give our doctors more confidence in our abilities to assess this pain?
Shyla, I'd like to acknowledge your comments and honor your point of view. If you're a confident and capable LPN, you have wonderful assessment skills and you're absolutely safe to do all this. Unfortunately, not all LPNs are cut out of the same cloth. And I've had some scary experiences with LPNs and some wonderful experiences. And the key is personal relationship. If you and the doctor know each other and have a clear assessment of each other's strengths and weaknesses and respect each other's professional scope of practice, then you can have a wonderful relationship. And if you don't have that personal relationship and the GP doesn't know you, some of them are shy. And let's face it, there are many GPs who are opiate averse. They're opiate phobic for various reasons that the college has done to us. And in long-term care, that's a real handicap. I periodically am asked by directors of care to come help them with facility physicians who just won't prescribe adequate analgesia. And yes, Shyla, it's a real issue. And my suggestion would be, if there are specific physicians who have a particular issue with this, get your director of care to talk to your medical director and have the medical director as physician approach the physician and say, I've got some quality of care issues. I'm seeing a lot of poorly treated pain in the building. Our pain scores are up. And I'm wondering if we can talk about how we can do a better job here. Yeah.
Shyla, I'm not a physician, so I can't speak for them, but I am a nurse practitioner. So when a nurse contacts me either by phone or in person and presents the situation thoroughly, communicates it well, does the pain rating, then I'm confident to order, range doses, because I pretty obviously you know what you're doing. So just communicating it really well, your findings, that's really helpful for me.
Yes, thank you. Absolutely.
Hi, it's Moon from Little Mountain Place in Vancouver.
Welcome.
Thanks for your presentation. Just curious on your thoughts, and maybe you can comment on the use of pain management along with the antipsychotic drugs that's already existing in their medication management?
Tell me the question again. I'm not sure what it is.
Just comment on the use of opiates and alongside already existing antipsychotic medication as their regular med management.
Okay. Are we thinking about a patient with hip fracture or a patient who's on opiates and antipsychotics but doesn't have a broken hip?
Can be both. Can you comment on if there is some degree of fracture, not necessarily hip fracture, and no fracture at all?
Okay, I'm still not sure if I've got the whole question, but I'm going to try answering a few questions and see if I hit the right one. Shotgun approach. Patients who are on opiates are at increased risk of falls. Patients on antipsychotics are at increased risk of falls. Patients on both, plus some benzodiazepine, are at very high risk of falls. Yeah, absolutely. So we have to be careful. All these medications are sedating. If you're on opiates and antipsychotics, I'm going to be asking the nurses, is his face down in his soup every day at lunchtime? Is he sleeping face down in his supper? I would expect him to be quite sedated. Is he walking? Is he talking? Is his level of function diminished very significantly with all these sedating medications we're giving him? And is he terribly constipated? Yeah. So cautious to use those things together. This reminds me that I forgot to tell you that one of the most important things you can do when somebody breaks their hip is to stop nearly all of their other pills. They're not going to be taking oral medications within the next 24 to 48 hours. They won't be swallowing pills anymore. I go straight to injectable analgesia. We go through the MAR and say, what can we stop? And 3 days later, when they're not swallowing at all, we stop everything. And we have to make sure that there's nothing that we can, if there's anything that they really need that we can give as an injectable, can we do that? So go through the MAR as soon as they've broken their hip, eliminate most of the pills. Only the pills that are keeping them alive should be continued, knowing that they might be in the last week of their life. And by the time they're only taking sips of water, stop all of the oral medications. Don't ask the nurse to get pills. It's not going to work. Yeah. Did I answer your question?
Sorta.
Sort of. Is there more? Ask the part that you still need to hear.
No, just curious about the usage of opioids and the antipsychotic drugs altogether, balancing managing the responsive behavior and at the same time making sure that their pain is well managed.
Now I get your question. Absolutely. If my mom was having responsive behaviors and acting out and punching at carries because of untreated pain, and you turned up her antipsychotic 3 times to snow her and she still had untreated pain, I would be very, very righteously indignant. If my mom has pain, I want you to treat her pain. And if she's got responsive behaviors, I need to look for the cause. All behavior is communication for people with dementia. They can't tell us what their problem is. We have to figure that out. And they're telling us with their behavior, my world is not working very well and I'm going to hit somebody. So if we can find the constipation or the sleep disturbance or the untreated pain or the loneliness or the boredom or the frustration that's causing the behaviors and treat that. For patients with BPSD, behavioral and psychological symptoms of dementia, and I've tried everything that I can think of and we're still not getting anywhere, I'd sometimes do an analgesic trial. I just give them a little bit of oxycodone for a week to see what happens. And oftentimes, yes, I see the thumbs up, David. And a third of the time, on residents that we didn't think were having pain, they're happy and cheerful and singing at the breakfast table and not punching the carriers anymore. And I and the whole care team feel terrible because we were treating pain with antipsychotics. We were trying to snow them. So always look for pain. When in doubt, try a trial of pain medication to see. Yeah.
Thanks so much, Trevor.
If I had a choice of starting pain medication or starting antipsychotics, I'd always start with the antipsychotics first. Because if I start with the antipsychotics, my chances of discovering or fixing pain are zero. I need to try the pain first. That's a great question. Yeah. Okay, so if you're not sure, but I really want you guys to have those orange straps from the ambulance people. Next time you've got an ambulance in your building, they're coming to pick up a resident. Can you show me your leg immobilization straps, please, and follow them out to the ambulance, and they'll show you the orange straps. They're about this wide, and they wrap them around their legs, Velcro, zip, zip, and their leg is immobilized, and they're the world's greatest. And we should have them in all our long-term care homes to immobilize leg fractures, even if they're just going to go to the hospital, because we do this often enough that we should be able to make a broken leg comfortable even before the ambulance comes, and especially if we're going to treat them in the building. So, and my tensors work well enough. Jessica, you're on the phone. Can you talk to us about how well tensors work compared to the orange straps? I don't know if I'm putting you on the spot. Jessica's our care coordinator at Mountain Lake Seniors Community. I don't know if you might not.
Hi. So yeah, we're fortunate actually to have quite a few pairs of those orange straps, and they work very, very well when we have residents that will allow us to leave those in place. So with our residents that have advanced dementia, that can sometimes be a challenge, where we have to kind of get creative. But they're great. I don't know where we got them from, but I don't want them to ever disappear.
I could have told you a horror story. Jessica asked me to tell an easy story at the start and a more challenging story at the end. We've had the most challenging resident I've ever managed a hip fracture on in our building for 4 weeks. And most people with a hip fracture don't move an inch. They hold perfectly still and don't want you to move them either. This guy, he's got a broken bone sticking out, and family, he's old, he's 92, he's got all these reasons why he shouldn't be still here, and he's still here 4 weeks later, and he's thrashing and moving and trying to climb out of bed, and he's got his legs over the side, he's got a leg that's flopping every which way, and he won't hold still. And it's been a nightmare trying to stabilize this and control his pain. We've had some meltdowns. I had an emotional conversation with daughter. Oh my goodness, this has been the hardest one I've ever done. So it's not always easy. It's not always a walk in the park, but 95% of the time, the pain is easy to manage. The residence is peaceful. They stop eating and drinking by the 3rd day. They slip away anywhere between about day 3 and about day 7. And it's so peaceful. And when they slip away quietly, the family look and say, we did the right thing. He was ready to go. I'm so glad we didn't do surgery. And that's very gratifying to hear that from families, for them to say, I'm so glad we didn't put him through. So glad he stayed here with us. Yeah, so that's very valuable. Okay, I think we're done. Oh, we're 15 minutes late. Look at that, Jessica. You let us run way too late.
No problem. Thank you so much for being here and speaking with us tonight. That was a great talk. Really appreciate you taking the time.
Lame duck.
Thanks, Trevor.
Oh, you're very welcome. So welcome. Thank you so much. Together, we're going to change the world, guys. We need to change practice. Yes, David. Yes, we're going to change this world. We're going to stop doing too much of the wrong things for our frail seniors and keep them out of the hospital and make them comfortable. Thanks. I'm going to share my speaker notes with you. I'm going to clean them up. It runs to 8 pages. It's long, but I'll just give it all to you, and you can just take the parts that you want and throw the rest away. That's good.
Perfect. Thank you so much.
Okay.
Good night.
Thank you
Have a
all.
good night, everyone. Bye-bye.